Department of Pathology. This slide didn't quite get completed, but that's okay, we'll just tell you. There's Dr. Fred Wallman, who's in laboratory medicine, and then there's Nina Vincent, who is advocate assigned to this particular segment in the education. And what we're going to do today is to talk about breast pathology. So, you know, essentially what happens when somebody has surgery, and the part that's taken out is taken to pathology, is processed, and we come up with a diagnosis, and it's going to include a little bit about markers such as estrogen, progesterone, receptor HER2, and some issues about tumor progression. And the way it's going to go is that Linda's going to start and talk about the perspective of the advocate, and then Fred Wallman and I will intersect with each other so that the issues sort of follow some kind of process throughout the lecture, so we will go back and forth. And we have the luxury of having such a small group, and I don't know how the previous lectures have gone. Usually in this room there's a lot of interaction, people ask questions and so forth, so I would encourage you to do that, to have it be as productive as possible.
Can you guys be less shy and come back over
Maybe
here?
It's easier.
You know, especially because we're focusing on these photomicrographs, you might find it a little easier.
The other thing is, can you hear us? Can you hear me?
And we're not going to use the microphone, so.
Yeah, I think it's nice enough.
Oh, yeah, you wanted to.
So Linda, I'm going to ask you to come right on.
No, I'm not.
It's your part.
I don't need to sign this. And then, if you haven't signed in, please do so. Pass it on. Thanks.
Well, I'm going to give you a patient perspective first, because that's how most of us have entered advocacy. We reluctantly become patients. There's a biopsy, and you're in this waiting period, waiting for the verdict. And someone will, a friend or relative, will hand you this book, and you go to the surgeon and find out what your pathology report is. And this book has an excellent chapter on how to interpret your pathology report, so that's the first step. And then as you go through treatment and you get through the initial shock of this diagnosis and how it's going to be treated, later you decide maybe you want to do something about it, and then you enter advocacy. And for me, advocacy, the best fit for me was here at UCSF in the SPORE advocacy program. Do any of you know what a SPORE advocate does? Anybody? Well, besides our SPORE advocates. Well, we are charged with reminding the researchers of what the patient perspective is. So we become patient-consumer advocates, and specifically, most of us here become research advocates. And we do sit on Komen reviews and vote. 1/3 of our vote counts toward whether that research application that you write in to Komen is funded or not. And we get a lot of education here, and we go to Project Lead and get more education and become more versed in the published research on oncology. And start looking for, we start looking for, we need guidelines on how to look at this research. We're not going to just be emotionally responsive to this research. And so one of these guidelines was mentioned last week was the remark criteria for tumor markers. Basically, this is for publications in the oncology journals. And basically what this covers is assay methods, if they're standardized, the reagents are standardized, if the data is appropriately handled, if the statistic methods are handled appropriately, what they are, what the conclusions are, and in this way, tumor markers can move out of the research labs and hopefully into clinical use. And I'm open to questions. We are open to engaging with you in your research. We are volunteers. We do not get paid for this work. That's what that means, volunteers. Okay. So if we want to engage with you, if your project looks interesting to you, we will. But we are volunteers, and our time is limited in doing some of that.
Thank you, Linda. Linda's been part of the group for many years. I don't know how many anymore, but I think at least 10 years, right?
Yeah.
Yeah. And it's been very helpful to have that perspective and also to help us to advocate for what we think is important. So it really is very much a two-way street. So you're going to
I'll
forward?
do that.
Oh, okay. All right. So why don't we go to the next? So I'm going to assume that you don't really know anything about oncology. Some of you may already, and others may not. So I'm going to take it from square one. And if something isn't clear, then let me know. So when you look at the breast, it is composed of sort of tree-like structure, where you have the big duct that comes out on the nipple, and then it branches into many, many smaller ducts, and then at the end are lobules. And each tree has many, many hundreds of this, so this is a simplification of what's there. And then surrounding the lobular structures are a fair amount of fatty tissue and also some fibrous stroma intersecting with this. So what we're most interested in most of the time is this epithelial lining that is present in this tree-like structure. That's where breast cancer starts, and we'll get back to that. Now, this is a little bit slightly different picture of the same thing, but some lesions intersected with it. So you have this one tree here with a duct coming to the nipple and then occupying a part of the breast. And most people have somewhere between 7 and 15 of these tree-like systems in a single breast. So you can have a cyst, you can have a fibroadenoma, which is a benign process in the breast. You can have an abscess, which is an infection. You can have what's used to be called fibrocystic disease, is the change to fibrocystic change, because it's not considered to be a disease process at this time. You can have a cancer. And all of these have different appearance when we look at them in the microscope next. But what I wanted to start with is to try to translate the view from the three-dimensional, what you think of as a breast with the tree that goes in that clearly has 3 dimensions to it, to the 2 dimensions that we look at in the microscope, which is quite a different view. So next, say we have one of these branching structures here, and then we take a piece of tissue out of that area, and the orientation of that is going to be random. We don't really know what the direction of the duct is, so we just take, because we can't see the ducts, they're too small to see with the naked eye, so we just take a piece of this, and it's sort of like a rectangle about 3-4 millimeters thick, and then you cut a very thin section from this, and what's going to be projected on the slide typically is a cluster here from the lobule that came from this end part of the system there. The next piece is going to be a cross-section of that duct, or small ductule. And then again, there's another lobular structure and another duct. And this is what you're going to see on the slide. So it's a very different perspective next. So here's a fairly high power view of a normal breast. So this would be a cross-section of a ductule. This is a small duct of a lobule, and this is a little ductule. And this ductule may not belong to this lobule. It may belong to something up here. So you can, when you see the cross-section, you can't really say which ductile or which duct is associated with which lobular structure, because there's a lot of overlap between these different trees. So here's another small ductile, and this looks like it's part of a lobule, and here's another lobule. Next.
Rita, are you going to talk about the other cells that one can see in this photomicrograph as well?
Well, yeah, we could do that. So there's a little bit of this intersecting stroma in between, and those are sort of fibrous cells. Those are not epithelial cells, and this is something that's present